Hello, everyone, and welcome to Stanford Care's monthly Community Health Talk series. My name is Anamika Ghosh, and I'm a first-year physician assistant student here at Stanford School of Medicine. I'm really pleased to bring you this series of talks co-sponsored by Stanford Health Library and the Vincent V.C. Wu Foundation. Today, I'm delighted to welcome Dr. Eugene Yang, who will be speaking on heart diseases in Asian Americans, what you need to know to lower your risk. Asian Americans are the fastest growing ethnic group in the United States. While heart disease is the leading cause of death for most Asians, our risk isn't the same. In this talk, you will learn about the differences in heart disease risk among different Asian subgroups and understand ways that you can lower your risk through lifestyle and behavioral changes. Dr. Yang is a professor of medicine in the Division of Cardiology at the University of Washington School of Medicine and holds the Carl and Renée Behnke Endowed Professorship for Asian Health. He received his undergraduate and graduate degrees from Stanford and his medical degree from the University of Pennsylvania. He completed his internal medicine residency and fellowships in cardiovascular disease and advanced cardiac imaging at Stanford. Dr. Yang is also chair of the ACC Prevention of Cardiovascular Disease section, vice chair of the ACC Asia Pacific Scientific Conference, and member of the ACC Annual Scientific Sessions and Lifelong Learning Oversight Committees. He co-chairs the Hypertension Working Group for the ACC Prevention Council and is the director of the Asian Health Initiative and co-director of the Cardiovascular Wellness and Prevention Program at UW-Medicine. His research interests include understanding cardiovascular risk among Asian subgroups and developing new technologies for video-based blood pressure measurement. We are very grateful to have Dr. Yang here today, so I'll go ahead and pass it to him to get us started.
Thank you very much, Anamika, for that very kind introduction. And it's nice to be able to give a presentation to the Stanford community that I benefited from for many years when I was in college and graduate school, then ultimately as a physician there. So I'm going to share my screen. So as Anamika mentioned, the talk today is going to focus on heart disease in Asian Americans and what you need to know to lower your risk. So these are my disclosures, and none of these are relevant to the discussion that we're going to have today. So what I hope to do in the next 40 minutes or so is to talk about Asian and Asian American demographics. We will talk then about heart disease risk in Asian Americans. We'll review the major risk factors for heart disease and opportunities to optimize those risk factors. Then finally, we'll talk a little bit about what are things that you and the community can do to help improve cardiovascular health, specifically in the Asian population. So as Anamika mentioned, Asia, as we all know, is the largest and most populous continent and represents 60% of the world's population and comprises 48 countries and 3 territories. More than 4.7 billion people live in Asia, and in the 20th century, the population has quadrupled. Additionally, as you know, China and India account for more than 1/3 of the world's population, and India is expected to surpass China in overall population sometime later this year. What about in the United States? So we know that currently about 20 million residents of the United States are of Asian origin. And in fact, 3.5 additional million people identify as mixed-race Asians. Furthermore, the Asian American population almost doubled in the past 20 years, and it is projected by 2060 for there to be more than 46 million Asian Americans, and we will be the largest immigrant group by 2055. So this is summarized and highlighted here. So you can see that we have seen a dramatic increase in the Asian population between 1980, 2019, and you can see that projection for 2060. And then when we look at these projections, you can see Asian Americans are gradually increasing in their distribution as the immigrant population. And you see that by 2055, Asians will surpass Hispanics as the largest immigrant group in the United States. Let's talk a little bit about Asian American demographics specifically. And we know that about half of all Asians live in the West. About 30% live in California, followed by New York, Texas, New Jersey, and Washington, where I reside. More importantly, about 85% of all Asian Americans are represented by these 6 Asian subgroups, specifically Chinese, Indian, Filipino, Vietnamese, Korean, and Japanese populations. And about 6 out of 10 are born outside of the United States. And Asians who live in the United States tend to be younger than our other racial counterparts at 34 versus 38 median age. And you can see that 72% of Asian Americans report as being English proficient, and about 27% live in multi-generational families. So again, we can see these things highlighted graphically here. So again, we look at the 6 largest Asian subgroups that represent 85% of the US population overall. And then we can again see that about half live in the western part of the United States, and about 3/4 live in the West and the South. And then when we look at English proficiency in speaking English, you can see that 72% report being proficient. And among those who are US born, it's about 95%, whereas it's about 57% if you're foreign born. Other things that are very important is that we tend to view Asians as being economically very healthy in terms of income levels, which is true that Asians overall have an income about $86,000 per year, which far exceeds the US average of 62,000. But you can see that there are tremendous disparities. So Indians on average earn much higher incomes of 119,000, whereas Burmese and many of the Southeast Asians actually have income levels that are lower than the median annual income in the United States. So again, there are disparities in terms of overall economic indicators among the different Asian subgroups that frequently does not get discussed. So I think it's really important to understand, is our risk of heart disease the same? So being a very bad golfer, I like to think about the fact that we have many golfers that are of Asian descent who play in the professional tours. And so if we look at a new golfer sensation, Tom Kim, who's Korean American, or we look at the Chinese golfer, Shen Fang, or a Fijian golfer, or a Thai golfer, or a Japanese golfer, people have tended to put us all in the same category. And so even though we are of different origins from specific countries, we tend to be put together when we estimate our risk of heart disease. And as we'll talk about shortly, that is something that we really need to not do if we're going to better understand what our overall cardiovascular risk looks like. So to give you some context, this is a very common patient that I will see in my office. So here we have a 70-year-old man who has many of the traditional risk factors that many Asians have at this age. So he has a history of high blood pressure, he has high cholesterol, he has pre-diabetes, he smoked but quit about 15 years ago. And his diet, as somebody in this case, let's assume that he immigrated from Korea, is typical Korean food. So he eats rice and noodles almost every day, just like my parents do, 2 or 3 meals. He is active and walks 45 minutes a day for 5 days a week, and he has no cardiac symptoms. And you can see he has 1 blood pressure medication that he's taking. If we then review his physical exam, you can see that his blood pressure is 138/85. His body mass index, which we will talk about, is 24.9. And you can see his lab values are actually not bad. I mean, his cholesterol level is 200. His bad cholesterol or LDL cholesterol is 148, which is a high. His HDL cholesterol or good cholesterol is 42, which is not terrible. And his marker for diabetes, which is typically what we calculate as the hemoglobin A1C, is 5.9%. So we'll review a little bit of this shortly. So how do we estimate your risk of having a heart attack or dying from a heart attack? So as a cardiologist, the American College of Cardiology is a professional society that has created a calculator to estimate cardiovascular risk. So when we put this patient of Korean descent who's 70 into this risk calculator by putting his blood pressure and his cholesterol levels, he smoked but quit more than 5 years ago, you can see that his calculated risk of having a heart attack or dying in the next 10 years is very high at 25.3%. So that means that he has a 1 out of 4 chance of having a heart attack or fatal cardiac event in the next 10 years. So that is extremely high, and this would be considered a high-risk patient where we need to aggressively treat some of the risk factors that we'll talk about here shortly. One thing that's really important to acknowledge is that, as you can see here, when we look at race, you can see there is a specific designation for white and African Americans, but because this patient is Korean, he's classified in the other category. So what does the other category mean? So the problem is that anybody who is not white or African American, the risk that is used to estimate cardiovascular risk uses the default white risk calculator. And unfortunately, because of that, you can see, as I've underlined here, that the risk may be underestimated in some racial and ethnic groups. As you can see, those of South Asian ancestry, whereas may overestimate the risk in some Asian Americans, specifically those of East Asian ancestry. So as you can see, the risk is not accurate because we don't have a specific risk estimate for Asian Americans. And you can see that there are differences among different Asian subgroups. And so as a result of this, this specific risk calculator cannot easily be applied to Asian American populations. So just to give you some context, so these are some colleagues and researchers in Korea. And so they did a study to try to see how well the traditional risk scoring system in the past in the United States was something called the Framingham risk score, and compared that to a Korean population to see whether there would be consistencies in terms of the risk prediction model. And it turns out that the risk prediction model, when they looked at Korean populations, significantly overestimated the risk compared to this Framingham risk score calculator, therefore showing that it really could not be applied to Korean populations. And to give you an example, so this is the same patient that I showed you using the US risk calculator, but if you plug it into the Korean risk calculator, you can see that this patient's risk is almost 10 times lower than what would have been characterized in the US risk calculation estimate. So again, we see that there's a major disparity between what we calculate from the current risk models in the United States and what might be estimated in Korea. Now, obviously the challenges are this is not really comparing apples to apples because we can't say that Koreans are the same as Korean Americans, but what, as I will show you, that we do know that the risk in East Asians is much lower than it is in other Asian subgroups. So this really highlights why I do the research that I do as a Korean American. The Korean American's risk will not be the same as an Indian American or a Filipino American, but in general, in clinical research and trials, Asians tend to be all lumped together, as I said. And so as a result, trying to discriminate differences in risk of not just heart disease or response to treatment for cancer, we really don't know because we are significantly underrepresented in clinical trials. And as I will highlight, we know that there are major differences in heart disease risk. We know that South Asians are at the highest risk. We know that East Asians tend to be at much lower risk. And so the importance of disaggregating the Asian subgroups will allow us to provide more culturally specific recommendations in order to lower the risk of heart disease for the different subgroups. So this is an example of why there's been this belief that Asians' risk are low. And so if you look at this graph here in green, you can see the risk of cardiovascular death between 2000 and 2013. And if you lump all the Asians together, our risk is much lower than Hispanics, non-Hispanic Blacks, and non-Hispanic whites, and lower than non-Hispanic American Indian and Alaska Native. So when you look at this, you say, okay, our overall risk is twice, Blacks' risk is twice the risk of Asian Americans, and our risk is about maybe 1.5 times lower than it is for non-Hispanic whites. So therefore, our risk is actually low, and so maybe we don't need aggressive treatment. However, when we look at this study that recently came out last year from Dr. Shah at Northwestern, you can see some alarming trends. So this is looking at cardiovascular mortality between 2003 and 2017. And this is, again, disaggregated data. And what you can see here is that for this Korean patient, let's say, Koreans are highlighted here in orange, that cardiovascular mortality for Korean American men is actually quite low. But then when you compare that to Asian Indian Americans, you can see the risk is almost double or more than double the risk of Korean American men. So again, we see that there are significant differences, and the trend in South Asians is alarmingly going up, probably at the fastest rate, whereas you see these other subgroups, non-Hispanic whites and other Asian subgroups, where some of these are flat or still going down, but not having this kind of increase in slope that we see here. And even more troubling is that when we look at Asian Indian American women, their cardiovascular mortality is even higher than non-Hispanic whites. So again, an alarming trend, whereas East Asians, you can see Japanese, Koreans, and Chinese have much lower risk among women in terms of cardiovascular mortality. So again, when you disaggregate the data, you see that there are significant differences, and therefore we should not all be treating Asian Americans the same in terms of their cardiovascular risk profiles. So what are the risk factors that we need to pay attention to? So the Life's Essential 8 is a product of the American Heart Association, and this update just came out last year. And so there are 8 specific factors that we know contribute to our overall optimal heart health. So we will review these individually. So healthy diet, physical activity, blood glucose level to monitor for pre-diabetes or diabetes, healthy weight, blood cholesterol, blood pressure, avoidance of tobacco products, and then finally, the newest thing that was added was healthy sleep. So in the past, there were 7 specific healthy lifestyle interventions, and now healthy sleep was just added this past year. So let's talk about our Asian diet. So we know, and I know you know, that we eat a very high sodium diet. Interestingly, unlike Western diets, we tend to get more sodium from the foods that we eat and cook and less from processed food. So for example, in rural China, 70% of the sodium in rural China comes from the food they're actually cooking, whereas in the United States, 70 to 80% comes from processed foods, pre-packaged foods, crackers, cookies, things like that. Additionally, Asians tend to eat higher sodium density foods compared to other racial groups, and that's even true here in the United States. So we really need to focus on reducing sodium intake in our diet, using salt substitutes, using less sodium sauces and soy sauces, and eating less rice and noodles. And I'll sort of explain that to you here in a minute. One of the interesting things that I've seen and have observed is there's a lot of interest in creating nutrition and dietary recommendations that are culturally specific. So I put a link here to a program that is done here at Stanford called the Stanford Nourish Project. So if you go to this website, you can see that they provide some recommendations on ethnically specific diets for South Asians, for Koreans, for Japanese, for Filipinos. So there are ways that we now have opportunities to see healthy diets that are specific and to our individual cultures. So as I was saying earlier, sodium intake is the highest in Asia. So you can see when you look at the Asian continent that the red and orange represent the highest sodium intake. And you can see that this is definitely very unique to the Asian population, whereas other parts of the world, even in the US and Central and South America, have much lower consumption of sodium relative to the Asian continent. So highest Asian intake in the world. And then if we do studies looking at the United States, we see the same thing. So here highlighted in these purple bars that compared to other ethnic groups, Asian Americans have the highest amount of sodium content in the diet, almost 4,000 milligrams a day. And then when we look at sodium density, you also see that sodium density is the highest in purple among Asian Americans. And then when we look at what are the foods that we consume that contribute to all of this sodium, you can see that for Asians, it's soups, rice, breads, and stir fry and soy-based sauces. So opportunities for us as Asians to try to reduce our sodium intake is looking at these specific targeted food areas or categories to try to lower our consumption of sodium. And I was mentioning earlier, there is this study that was published last year, actually now 2 years ago, from rural China, where they looked at patients who had a history of stroke and high blood pressure. And since, as I said earlier, that in rural China, in rural parts of Asia, they tend to use more sodium as part of their cooking, when they substituted 100% sodium chloride with a mixture of sodium chloride and just 25% potassium chloride, in this study, they showed that it reduced blood pressure, but also lowered the risk of stroke, major cardiovascular, and deaths in the population that actually were randomized to this salt substitute group. So again, showing that just making some mild modifications in sodium intake can have profound effects potentially in reducing overall cardiovascular mortality. So let's move on to physical activity. So I'm not going to go too much into detail, but I just want people to recognize what are the current recommendations for exercise. So in the US guidelines, the current recommendation is to at least do 150 minutes a week of moderate intensity exercise, and we'll go through what that means, versus 75 minutes of high intensity exercise. So then if we look at what represents moderate intensity exercise, you can see that brisk walking, 2 to 4 miles an hour, biking leisurely at 5 to 9 miles per hour, yoga, recreational swimming all constitute moderate activity, whereas vigorous activity are those who bike at a higher rate, who swim laps, who jog. And to give some context to this, so what about Asians? So Asians might like to do things like Tai Chi. So it turns out Tai Chi is considered a moderate intensity activity. And so it basically is in this range of between 4 to 5.9 metabolic equivalents, and is around 4 metabolic equivalents. So if you do Tai Chi 30 minutes, 5 days a week, that would constitute moderate intensity exercise. All right, well, let's talk about, again, the fact that we aggregate all of us together. And what we know is that we don't all have the same exercise habits and behaviors from a cultural standpoint. So this is a study that actually we just published through the Stanford Care program last month. And one of the things, excuse me, we were interested in was trying to understand how does acculturation impact cardiovascular disease risk factors. And so acculturation literally incorporates things like the time or duration of living in the United States, your proficiency in English, your citizenship status. And so what we have seen in the past is that the more acculturated you are, meaning that you live longer, your English proficiency is better, that tends to be associated with an increase in some of these risk factors, which we found that in general, higher level of acculturation was associated with higher blood pressure, higher cholesterol, diabetes, and obesity. But we found that were major differences among these Asian subgroups. And one of the things that was very striking was that Asian Indians, whereas all the other major Asian subgroups, including Filipinos and Chinese, at least that we could disaggregate in this study, were more likely to increase their activity level, Asian Indians did not really have any improvement in their physical activity for those who were more highly acculturated. And interestingly, I had given the opportunity to give some presentations in India earlier last year. And I was sort of amazed by the fact that in especially the large cities, they have a lack of sidewalks. There are not a lot of public spaces for people to do any kind of regular exercise. So the conditions were really not very, I think, conducive for people to exercise. So clearly, the location and country of immigration and the environment will dictate whether some of those behaviors that don't exist there can translate into opportunities here in the United States. And for Asian Indians, it's very uncommon for people to engage, at least at a high level, in physical activity, unlike other parts of Asia. So that gives us an opportunity to say when South Asians are at the highest risk for cardiovascular disease, encouraging an increase in physical activity might be a beneficial strategy to try to lower their cardiovascular risk. Let's talk about blood glucose and diabetes, because this is very relevant to the Asian population. So as you can see here, unfortunately, 1 out of 2 Asian American adults will have prediabetes or diabetes, and about 50% with diabetes are not even diagnosed. You can see Asian Americans are 40% more likely to be diagnosed with diabetes than non-Hispanic whites, 60% more likely to be diagnosed with kidney failure or end-stage kidney disease. So our risk of complications associated with diabetes and the overall risk of developing diabetes is higher. And that is very important for all of us to know your numbers. And so we'll go a little bit into detail here, but hemoglobin A1C is basically a blood test that measures the average blood glucose level over the past 2 or 3 months. And you can see the thresholds here. So for all of us, especially those of us who are at higher risk, that we really want to know what our numbers are. And so these are really the most important numbers to think about, which are that if your hemoglobin A1C is greater than 6.5%, that is classified as being in the diabetes range. Pre-diabetes is between 5.7 to 6.4, and then the normal range is less than 5.7%. The other way that we can also assess blood glucose and potentially diabetes is if you have a fasting blood test, like you might get for a cholesterol screening, and if your fasting glucose level is above 126, then you are in the diabetes range. So again, as I pointed out earlier, the risk of diabetes in Asian Americans tends to be higher than in non-Hispanic whites by 40%, 30%. But the other thing, again, is that we're not all the same. Our risk of diabetes is not the same. And that is highlighted here, that you can see that Asian Indians have a 12.6% age-adjusted percentage diagnosis of diabetes, whereas Chinese Americans, you can see the risk is only 5.6%. So again, there's almost double or more than double the risk of diabetes in Asian Indians compared to Chinese. So again, we need to be able to disaggregate and see these differences as ways to look for opportunities to improve some of these cardiovascular risk factors in Asian Indian populations, more so than perhaps in the Chinese American population. So why is our risk of diabetes higher? So we know that our fat tends to be unhealthy. So even though Asians tend to be overall not as heavy as other racial groups, our fat tends to be unhealthier than their fat. So we have more visceral fat, meaning the fat sits inside our belly instead of underneath the skin. And that fat tends to be more metabolically active and more dangerous. So the other thing we also know is that some Asians have more fat relative to muscle mass. So having more fat, as I said, is a risk factor for cardiometabolic disease. And so we'll go into that a little bit more. And so if you want to know what your own BMI is, which essentially is measuring your weight relative to your height, you want to know if your BMI is greater than 23. So there is now, I would say, a strong reason for Asians who have a BMI greater than 23 to be screened for diabetes or pre-diabetes. There are also differences in our ability to produce insulin. And so there are some genetic causes potentially of why Asians may be at higher risk of pre-diabetes and diabetes. They're related to our genetic makeup that may predispose us to not being able to produce enough insulin or extra insulin to compensate when blood glucose levels go up. And then furthermore, we just have a diet that is enriched with simple carbohydrates. So rice, noodles, starchy foods in South Asian diets like potatoes are pretty common depending upon what part of India you come from. And so these things also can cause spikes in blood sugar levels that then increase our risk of diabetes and pre-diabetes. So as I was saying earlier, unfortunately, Asians tend to have unhealthier fat. So visceral fat or intra-abdominal fat is all this white stuff that you see here. And the white stuff on the outside is the subcutaneous fat. So these are people that have the same body mass index that you see here, but you can see that this person on the right has a lot more fat on the inside than this person on the left. So this is the distribution of fat that's more common in Asian Americans than it is in white people and Black people. So consequently, even though our weight is the same and we might have the same BMI, the reality is that we may be more at risk for cardiometabolic disease because our fat composition is different. So what can we do to combat this? So I listed a few resources here that are ways to look at assessing your risk, looking specifically at programs for Asian Americans at Joslin Diabetes Center. That's part of Harvard Medical School. They have a specific research program on diabetes for Asian Americans. So these are links that you can pay attention to. So clearly making major adjustments to diet is critical. Weight optimization, reducing calorie intake, increasing exercise to get your BMI below this 23 threshold is also very important. And this can be accomplished through exercise and activity. So what we also know is that when you exercise more, you extract more glucose from your bloodstream into your muscles, and that helps to reduce the overall blood sugar levels so that those numbers, when we test the hemoglobin A1C, can be lower. So all of these things sort of fit in together. So healthy weight, healthy diet, et cetera, are all intermingled. But as I said earlier, we know that there are things that are unique to Asians. So we have a higher amount of fat relative to non-Hispanic whites, and that with the same BMI, some Asians, and not always exactly the same as a group, but some South Asians may have higher amount of fat than white Europeans with the same BMI. And as I said earlier, we know that our fat is unhealthier. We have more intra-abdominal or visceral fat. That fat tends to be more metabolically active, which is not a good thing, and increases our risk of pre-diabetes and diabetes, and also is associated with more unhealthy cholesterol profiles. So these are more numbers that you need to be aware of. So if we use the standard BMI cutoffs that the World Health Organization has put forward, then many Asians would not be considered overweight. But now we have decided that we need to have more discrimination. And we know that at the same BMI, Asians tend to have more prediabetes and diabetes. So as a result, there's been a strong push to change those thresholds to define who is underweight, normal weight, overweight, and obese. And if we use the most stringent ones, which is this Asian Pacific BMI, you can see that an obese person is considered to have a BMI of your Asia Pacific origin of 25, whereas that would only be considered overweight if you are using the standard definition. If we look at sort of another definition from the World Health Organization for Asian BMI, they have a little bit less stringent cutoff. And you can see here that they choose obesity to be defined as above 27.5, whereas this Asia Pacific BMI defines it as greater than 25. So in my opinion, using either of these is fine. It's just that we need to recognize that we need to apply these lower BMI standards for Asian people. And if your BMI is above 23, then you definitely need to be screened for diabetes. So let's move on to cholesterol. So again, I think if there's anything that I emphasize from this talk, it'll be two things. And one of them is clearly around knowing your own numbers, right? So having accountability to know what your risks are. So we talked about getting a test for hemoglobin A1C for diabetes. And one of the other important numbers that you need to know is your cholesterol level. So we know that high cholesterol is associated with increased risk of heart disease. As I mentioned earlier, LDL or low density lipoprotein cholesterol is the bad cholesterol that you hear about. And this is what's associated with a higher risk of heart disease. Diets that are high in saturated fat will increase the LDL cholesterol levels, whereas diets that are high in unsaturated fats are associated with a lower risk of heart disease and do not tend to cause increases in the LDL cholesterol, but in fact, boost the good cholesterol or HDL and lower another sort of atherogenic lipoprotein, which are the triglycerides or carriers of the bad atherogenic lipoproteins. Other things that we often assume is that the Western diet is bad. So if we eat a fast food diet that has more saturated fat than our Asian diets, but maybe that's not in fact true. And I'll show you a study that highlights that. Additionally, there are differences in risk of high cholesterol. So again, we have found that when we started disaggregating Asian populations, that Southeast Asians may have higher cholesterol than other Asian subgroups. Importantly, it is, I think, for this audience to recognize that the US guidelines now recommend that you should have cholesterol screening starting at age 20. So in the past, we waited much longer until people were more into adulthood, but now we want to see what your cholesterol levels look like at a younger age, and then that should be then retested every 4 to 6 years. And then again, I tried to synthesize things together with respect to diet. So we'll talk a little bit more about this, but really what we want to do is to replace the unhealthy saturated fats with unsaturated, both mono and polyunsaturated fats, such as what we see in the Mediterranean diet. And this is one way to sort of improve our overall health is by incorporating a Mediterranean style diet. So how do we manage cholesterol? So what do we do? So I already showed you sort of this pooled cohort equation risk calculator that really doesn't apply to the Asian population, but here it's important to know what these standards are. So what are the most important things to recognize are that in the US guidelines, if you're in an intermediate or high risk category, the recommendation is to treat your cholesterol aggressively with medication. There's certain groups that regardless of what you calculate the risk to be, should be treated aggressively anyway. So if you've had a history of a heart attack or a stroke, or you've had open heart surgery to fix or restore blood flow to some of your arteries, or if you've had a stent to open up one of the blood vessels, you definitely need to be aggressively treated with medication. Diabetes patients are at high risk for heart disease. And so diabetic patients, irrespective of what this risk calculator comes out to be, in general should be aggressively treated for cholesterol with medication. And then those who have very high cholesterol, so if your LDL or bad cholesterol level is above 190, then you may have a genetic predisposition for high cholesterol called familial hypercholesterolemia, which is actually quite common and occurs in about 1 in 200 people. And Asians are just as susceptible to this problem as other racial groups. There's some sort of populations where it's enriched, but overall the risk of familial hypercholesterolemia is consistent across ethnic groups and racial groups. In the guidelines that came out about 4 years ago, there were additional risk factors to consider. So aside from the traditional things that we've talked about, like diabetes, cholesterol, high blood pressure, which we'll talk about, we also know that there are other sort of what we call risk enhancers that increase your risk of having a heart attack or dying from a heart attack, and those are listed here. And so you can see that if you have a history of chronic inflammatory disorders like HIV or rheumatoid arthritis, you have chronic kidney disease, there are some biomarkers. If you have a family history, so if you've had a parent who's had a heart attack at a young age or had bypass surgery in their 40s or 50s, then that's another risk factor. And then also one thing that's been emphasized more recently is that if you have any history of pregnancy-related disorders like preeclampsia or eclampsia, pregnancy-induced hypertension, we know that's also a major risk factor. So when we consider whether to aggressively treat somebody's cholesterol, these risk enhancers need to be incorporated. And the final thing is that it was recognized, as I said, that South Asians are at higher risk. So if you come from South Asian country, so if you're from India or Pakistan or Bangladesh, then those people should be considered for more aggressive treatment because of the increased risk associated with those individuals. And then there are a few other things to consider. So calcium score is basically a scan of the arteries of your heart to look for calcium. And we know that's another way to help provide risk stratification when there is some indecision about whether to aggressively treat your cholesterol or not. And then finally, if you're very high risk, then the current recommendations now recommend lowering the LDL cholesterol level below 55. Interestingly, in India, because their risk of heart disease tends to occur 10 years earlier than it does for Western people and Europeans, they recommend much higher and much earlier screening and much more aggressive treatment. So those who are in the highest risk category, they recommend treating the LDL or bad cholesterol level now to less than 30 based on the Indian lipid guidelines. What I was mentioning earlier was this question about, are Asian diets healthier than Western diets? So this study was interesting. It was done in Singapore about 2 years ago. And they looked at sort of the local foods that people were eating, and they looked at Western fast foods. And what was interesting is that, first of all, many people in Singapore did not eat fast food, or very infrequent, like 70 to 80% rarely ate or did not eat Western fast food. But then when you looked at the diet and you looked at total fat, you looked at saturated fat, even though these numbers are small, you can see that the local foods had more sodium, more fat, more saturated fat, and more cholesterol than the Western diet. So it calls into question that somehow our Asian diets are actually healthier than some of the Western diets that we assume are actually more fattening. So this just goes through the prevention algorithm. So I'm just showing this to you. I don't want to go through the great details, but essentially, if you've never had a heart attack, this is the algorithm as a cardiologist or your primary care doctor should be using to determine sort of what your risk of heart disease is or heart attack. And that's what's highlighted here. So I showed you if you're in the 7.5% or greater than 20%, you're in a risk category where you should be potentially treated with cholesterol lowering medication. And then if you're sort of in a lower risk category, then some of those risk enhancers that I showed you should come into play, such as a history of HIV, history of chronic kidney disease, South Asian descent. So again, this gives you at least a more holistic approach to thinking about how other risk factors might influence your overall risk. Excuse me. For secondary prevention, these are actually people who've had a heart attack, bypass surgery. You can see that the recommendations are different, that in general, if you're in a high risk category, that you should be treated with medication. One of the questions I think that came out in the pre-talk questions was around if you're over 75, if you're older. And so I think that we tend to be aggressive still in that population. So if you've had a heart attack or a stroke, we tend to treat those patients regardless of their age, unless comorbidities or other things come up. So we still are aggressive at treating it. And you can see here that there's less strength in terms of the recommendation, partially because the population has not been adequately studied to show a clear benefit in this population. And as I mentioned earlier, that updated guidelines now recommend more aggressive treatment. So if you've had multiple heart attacks, you've had stents and bypass surgery, then the recommendation is more aggressive treatment. and that's just highlighted here. So let's talk about diet. So, even though the first section of diet focused mostly on sodium, I want to talk a little bit more about what are dietary patterns we need to think about. So the Mediterranean diet probably has the strongest evidence in terms of reducing cardiovascular mortality. A study was published from Spain where they randomized people to eating a handful of healthy nuts like almonds and walnuts a day. Another group was randomized to consuming 3 or 4 tablespoons of olive oil a day. And the last group was typical Western diet, but tried to make it low in saturated fat. And what they found was that the group who were in the Mediterranean diet actually had about a 30% lower risk of heart attack and cardiovascular mortality compared to this standard low fat, saturated fat diet. So among the diets that have actually been adequately studied, the Mediterranean diet has emerged as being probably the most healthy diet, the healthiest diet, as well as the one associated with lowering your risk of having a heart attack. And you can see the foundation of the Mediterranean diet is around olive oil, whole grains, fruits, and vegetables, all the things we know are healthy. And then in the middle category, you can see nuts, low-fat dairy products, eggs, legumes, and then at the top where you should limit your exposure of in your diet are processed meats, red meats, potatoes, and sweets. However, if we look at the Western diet, you can see that the pyramid is in the opposite direction. We tend to eat most of this, some of this, and then very little of this. So by shifting that paradigm to a more Mediterranean diet, then that certainly is one way to improve our cardiovascular health. However, we are all Asians, or many of us in this audience are Asians, right? So are you going to tell my dad, who's Korean, to not eat kimchi or to not eat Korean foods? Of course not, right? That's not realistic. So we cannot expect Asian Americans to completely adopt a Western diet. But what are things that we can do? So clearly things that we can do. So if you're eating a diet that's high in saturated fat with beef and pork, eat less of that, right? Incorporate more vegetables and eat less red meat and pork. Eat more soy products. We already eat lots of soy products, so eat more soy products. So instead, for a source of your protein, instead of adding meat, you can add tofu. Switch out dairy products for soy, oat, almond, or other plant-based milks. So Indian diets traditionally have used ghee or clarified butter, which is extremely unhealthy for you. So instead of using that, try using one of these, either avocado, canola, or extra virgin olive oil instead of using the clarified butter. And then also you can see whole grains, eating more fish and seafood and less red meat and pork are some of the mechanisms that we can use to try to incorporate Mediterranean types of foods that are lower in saturated fat and higher in unsaturated fat while retaining our culturally specific dietary habits. All right, we're going to talk about a few more risk factors. So hypertension is a major risk factor for heart disease, and it's really probably the most important cardiovascular risk factor aside from smoking as a preventable cause of death. And we can see that there's an alarming trend that cardiovascular mortality has been increasing in the United States. And you can see that rural areas, especially in the South, have higher age-adjusted mortality over the last 10 years, whereas urban areas have higher mortality than most of the rural areas, depending upon the region. One of the things that is challenging is that, what is your blood pressure number and what is the blood pressure target? So there has certainly been controversy over that. But again, blood pressure is another number that you all should know. So blood pressure, your cholesterol, your diabetes numbers, those are all things that you should all be focusing on to assess what your cardiovascular risk looks like. And these are just the different stages of high blood pressure. So we published this paper about 3 years ago, looking at the differences in the guidelines for blood pressure targets. And the reason I bring this up is because in the Korean guidelines, the KSH, Korean Society of Hypertension guidelines, you can see that the blood pressure targets are higher than they are in the United States. And one of the reasons why is because in the Korean guidelines, it was recognized that the primary reason the US chose this lower number of 130 was based on a large US study that had basically no Asians in it. So the Koreans and other Asian guidelines, including the Japanese hypertension guidelines, Chinese hypertension guidelines, have not lowered their standard definitions. And a primary reason is because that there were no Asians participating in these studies. Again, we talked about sodium intake, so I'm not going to go through this again. But again, we know that sodium is a major cause of high blood pressure, and therefore lowering sodium intake is one way that we can help lower our blood pressure. which, as I said, is the primary risk factor for heart disease. So again, using salt substitutes, I already went through all these things. So again, I'm just trying to reiterate the importance of how reducing sodium intake is really one of the major things that we can do to improve our cardiovascular health. Tobacco cessation, obviously, I don't want to spend too much time, but we know that's a major risk factor associated 1 in 4 cardiovascular deaths. And the chemicals in cigarette smoke are dangerous, right? This is what contributes to our risk for heart disease. But more importantly, we see that there are differences among Asian subgroups in tobacco use, both just general tobacco use as well as cigarette smoking. So you can see in the bottom bullet point that between 2010 and 2013, 7.6% of Chinese Americans smoked compared to 20% of Korean Americans. So again, targeting certain populations for smoking cessation efforts, particularly the Korean American community, might be more important than it is to target the Chinese American community. So again, this study comes out of the Stanford CARE program. This was published last year and shows that when you look at disaggregated Asian data, you can see that Filipino men and women had a higher risk of smoking compared to Chinese and Asian Indian American, and in some cases higher or at the same rate or similar rates to non-Hispanic whites. So again, showing that we need to consider targeting certain populations overall in terms of who is more susceptible or who is more likely to need some sort of intervention. And then the final and the newest sort of risk factor is healthy sleep. So what is considered optimal sleep is at least 7 hours and less than 9 hours. And we have found that in studies that Asian American adults tend to experience lower sleep duration and poorer sleep quality compared to non-Hispanic whites. And again, as you would anticipate, there are disparities or differences between Asian American subgroups. First-generation immigrants report better sleep quality. East Asians may have better sleep outcomes compared to Southeast Asians, and sleep apnea is often underreported, specifically in South Asian communities. So this is a study that I'm working on through the Stanford CARE program that we're about to present in a few weeks. And in this case, because sleep is now one of the new risk factors, we wanted to see if we disaggregated Asian populations and looked at specifically cardiovascular outcomes like heart attack, stroke, cardiovascular events. Are there differences among Asian subgroups? And you can see that among the different Asian subgroups, other Asians typically comprise the other 3 largest Asian subgroups, including Koreans, Vietnamese, and Japanese, that you can see that the risk was about 60% higher, whereas when you compared it to Asian Indians, it was only about 16% higher, but this was not statistically significant. So again, showing that there are differences in how sleep may affect cardiovascular outcomes when you disaggregate the Asian populations. So what are things that you can do as an Asian American community? So as I probably highlighted extensively, that there's a need to have more representation in clinical trials. So if we're not sitting at the table, then we really are not involved in any of the decision making, right? So if we're going to be able to participate in clinical trials to inform the researchers, then that will help improve our overall health. So there are some programs that exist. So UCSF has something called the CARE Registry, and that's a registry where people in the community can volunteer to participate in registries to then potentially be involved in clinical trials. So that's one way that there is community opportunities to get involved so that when clinical trials come up that you might fit the profile of, you can potentially be enrolled in those studies to better inform about Asian American disease, not specifically just heart disease. And the Masala study is a specific study looking at South Asian communities and looking at why South Asians risk is higher by looking and dissecting out some of the risk factors, specifically in South Asian people. And then finally, the NIH has recognized that there is a need to fund more research looking at disaggregated Asian Americans. So in the near future, I think there are going to be opportunities to see programs and research funding that's going to be directed specifically at Asian American communities. And this is just an example as a cardiologist. So the NCDR is part of this sort of national data registry that we have in cardiology. And one of the nice things that you see now is that when we have patients who are undergoing cardiac procedures, in order to get better understanding and differences in risk, you can see that now there's disaggregation of the 6 largest Asian subgroups, as well as Asian Pacific Islanders. So again, I think these are ways that we're going to see opportunities to increase and enrich the research in this area. So my take-home points are that heart disease we know is a leading cause of death among Asians and Asian Americans, and there's significant differences in risk among Asian American subgroups. All Asian Americans should be evaluated for diabetes, especially if your BMI you calculate is over 23, for high blood pressure, for cholesterol. And as I just pointed out, there's a strong need for Asian Americans to be more involved in clinical research and trials to better inform clinicians like myself on how to treat Asian Americans better. Healthy lifestyle is the most important, right? So know your numbers, as I mentioned, and then what are dietary changes that you can make? So clearly adhering to a low sodium diet, reducing intake of processed foods like soy sauce as well, eating less rice and noodles and other simple carbohydrates, eating more unsaturated fats from fish like salmon or nuts, and less saturated fat from red meat and pork. And then exercising regularly. So 150 minutes a week of moderate intensity exercise is the minimum that improves overall cardiovascular health. I will also say that if you can't achieve that, something is better than nothing. So even if you do 50 minutes, your risk of having a heart attack or dying is lower than somebody who's 20 minutes. So there is somewhat of a linear relationship between the amount of exercise and cardiovascular outcomes. Optimization of weight through some of the things we mentioned, including diet, exercise, avoiding tobacco products, and I mean all tobacco products, whether it's e-cigarettes or regular smoked cigarettes, and then getting enough sleep. So with that, I will end, and I thank all of you for participating in this session today. Thank you.
Thank you so much, Dr. Yang. That was a really, really informative talk, and I think I learned a lot. I think we still have time for maybe one or two questions. From the pre-questions that were submitted, I noticed a general trend about the concept of nature versus nurture. And I think there's a lot of preconceptions about what we can do right now in our lives and how our behaviors can actually affect our health outcomes versus what might already be set in stone from genetics. Do you mind talking about that a little bit?
Absolutely. So I think there's some questions also about this in the chat. So I think one of the most challenging areas that we have, honestly, is that now we have Chat GPT, technology, high throughput. All these things are allowing us to review and see lots of data, and so we can do things that we do even at Stanford and many other institutions are called genome-wide association studies, where we can link mutations in specific genes and risk of heart disease, cancer, whatever you're looking at. And so, in fact, there are now things called the polygenic risk score that applies a combination of mutations in different genes that can be applied to say that if you have a risk score based on mutations that you have in these genes, is that additive in increasing sort of your risk of heart disease? So absolutely, studies have demonstrated that you can do that. However, one of the key things that is important is that the additive information that these types of genetic studies inform us on in terms of our risk is relatively small. So the contribution of genetic differences, yes, there's some things where genetic contribution, if you have a gene for high cholesterol, that's different. But in general, most of the genes that are associated with heart disease tend to have a relatively small impact. So I think down the road, when we think about precision medicine, where we have genetic information, laboratory information, and other things, then maybe we can get a more comprehensive and specific risk assessment. But we just have problems doing the basic things, which is just recognizing we need our blood pressure treated, recognizing we need to eat healthier, recognizing we need to exercise more. So those are the big things that we are very unsuccessful at doing now. So if we just focus on those things, the benefit in terms of reducing our risk of heart attack and cardiovascular events, the benefit is enormous. So focusing on the genetics is not as important, frankly, as focusing on all those 8 things that we just talked about here today.
Absolutely. Thank you.
So I'm just looking through some of these things. And so I think it's hard. I think a few things that often people ask questions about, and there's one about ratio versus actual cholesterol numbers. There was a question about doing advanced lipid profile testing. So what I will tell you is that what we have learned in the last maybe decade is that some of these things were used to calculate the ratio of total cholesterol to HDL, good cholesterol. Having a high good cholesterol was protective. A lot of those things have lost a lot of steam. So we know now that having a very high good cholesterol actually may be bad, and that it increases your risk of having a heart attack or death. So in HDL cholesterol above 80, we used to think, oh, your HDL cholesterol is really good. Well, it turns out now that that may not be good, and in fact is associated with a higher risk of heart disease. So the focus now in cardiology is the LDL cholesterol until proven otherwise. So lowering the LDL or bad cholesterol as low as possible is really the most important. So having a high good cholesterol is maybe not good. In fact, somebody talked about having a high HDL. That may not be good. What you really need is to have a very low LDL cholesterol. So physiologically and in general, you don't really need much LDL or bad cholesterol. So in a rhinoceros, their total cholesterol level may be 80 to 100, and their bad cholesterol level is about 30. A newborn baby has an LDL cholesterol that's about 30. So it tells us that we really don't need to have much LDL cholesterol. Most of the organs that produce cholesterol are sufficient in making enough in the liver and in the brain and the intestine. So you actually do not need to have a lot of cholesterol circulating in your bloodstream in order to maintain normal cellular function. Okay, I'm going to try to see some other things that people. So there's a question about diets like keto and intermittent fasting. Are there specific differences in agents? So I think, as I mentioned in this talk, that the ketogenic diet or the Mediterranean diet has the strongest scientific evidence. Ketogenic diets, which are low in carbohydrates and high in saturate or high in fat and protein, have not really been well studied in, I would say, well-designed clinical trials. So we don't really know specifically what the long-term effects are or what they are beneficial or not in terms of protecting people from heart disease. That being said, again, there's a counterbalance because we don't want a high simple carbohydrate diet, especially since Asians tend to be at increased risk of heart disease or diabetes, I mean. On the other hand, we don't want to negatively influence our cholesterol levels. And so a diet that is high in protein and fat, I advocate for high in healthy protein and fat through either nuts, fish, as opposed to what I've seen just today in clinic before I started this talk is a patient who says, she's on a ketogenic diet and eats, red meat 2 or 3 times a week. That is not a healthy diet. So again, I think we don't know the answer. Intermittent fasting in terms of weight reduction, we don't really know. In fact, studies now have suggested that intermittent fasting has no effect on lowering weight or reducing weight. But specifically for Asians, I think the issue is like, what kind of ketogenic diet are you going to eat that incorporates Asian specific foods? So again, I don't think that's really been studied. So the key thing is really to focus on healthy fats and protein and not so much about the specific type of diet, honestly. I wish I could answer all of these questions. I cannot. So I think, if there are a few key takeaways, I think the key things are knowing your numbers. So knowing what your cholesterol levels are, your blood pressures are, your hemoglobin A1C, if your BMI, and calculating your BMI to determine whether you need to have your hemoglobin A1C or blood glucose levels checked. So knowing your numbers. And then 2 is any kind of intervention you can do to optimize your health. So nobody's saying, and I tell patients this, I don't expect if I see a patient, they're going to make optimization of all of those 8 factors. That's not realistic. So think about one thing that you can do that you think is realistically something you can accomplish. Obviously, all of those things are important, but think about 1 or 2 things that you can actually intervene on that you can actually accomplish, because you're not going to be able to fix everything at once. So I usually give patients a goal. All right, your goal in 3 months is you're going to increase your exercise to 150 minutes a week. They may not be able to decrease their alcohol, may not be able to change their diet, but at least they can do that one thing. And then we build upon that. So I think you want to sort of model your behavior to be successful. If you try to model your behavior that you're going to fix all these problems at once, that's usually not going to work.
Dr. Yang, thank you so much for your time and for speaking on such an important topic. And thank you to our audience and everyone who joined us this evening to learn more about cardiovascular disease in the Asian community. We hope that you'll be able to join us again next month on February 21st for CARE's next community health talk on gout in the Asian population, and that'll be from Dr. Ji-Sun Hong. Thank you, everyone, and have a wonderful night.
Great. Thank you very much.